Mic check 1 2. All right, good. So this is going to be the first in a series of step 3 review modules. Modules, I don't even know why I called it that. But this is step 3 review, so it's going to be a bunch of random facts that I'm going to talk about and a small explanation as to why the facts are what they are. Okay, so we'll start with the first one: suicidality. If a patient comes in and there's some sort of idea that the person had suicidal ideation, either they or somebody else observed an attempt on their life, or they were just saying that they wanted to kill themselves, right? You bring them in for psychiatric evaluation in the emergency room. The main thing here that I want to say is if they are intoxicated, that was too much talking. If a person comes in with suicidality while they're intoxicated, don't take their word for it. Don't take anybody's word for it. You need to wait until whatever drugs or alcohol gets out of their system, and then you do an evaluation for suicidality again. Example, somebody comes in, they're drunk after they said that they were going to kill themselves, and as they're still drunk, right, in the question stem, it'll tell you that they're slurring their speech, they have unsteady gait, whatever it may be, right? There are physical symptoms of this intoxication. You do not pay attention to anything that they say. You have to wait until their blood alcohol level goes down or until the drugs leave the system, and then you reevaluate for suicidality at that time. Continuing on the trend of suicidality, we have risk factors and protective factors for suicidality. So let's go through the risk factors. Psychiatric disorders, prior suicide attempts, hopelessness, whatever that means, never married or divorced or separated, living alone, unemployed or unskilled, physical illness, family history of suicide or family discord, access to firearms, substance abuse, and impulsivity. Then we have protective factors, which are social support, family connectedness, pregnancy, parenthood, religion and participation in religious activities, right? So a lot of risk factors that there are. One of the things I want to highlight is that the biggest risk factor for suicidality, the biggest risk factor is a person who has attempted suicide before. That is it. All right, so the next topic is Cushing syndrome. So the evaluation of Cushing syndrome is essentially going to start with a screening test. And the screening test is going to be 3 different things that you can use: either a 24-hour urinary cortisol, a late night salivary cortisol, or a low dose dexamethasone suppression test. The low dose test is essentially testing out to see if the hypothalamic pituitary adrenal axis is intact. If you get a very high cortisol after that dexamethasone suppression test, then you know that there's something wrong with that hormonal axis. And so the low dose is the screening test. After that, once you've done the screening, the next thing you want to do in the actual evaluation to confirm whether the person has Cushing syndrome or not is to get or not Cushing syndrome or not, but basically to see what the most likely cause is you get the ACTH level. And once you get the ACTH level, if it's low, then you know that that must be an adrenal source that is giving up that cortisol. And so in that situation, you're going to go ahead and you're going to do an adrenal CT. If the ACTH level is high, then in that situation, we know that the pituitary is contributing to that. And so we're going to do a pituitary MRI and or do a high dose dexamethasone suppression test. Another possibility in this situation of ACTH being high or near normal is an ectopic source of cortisol. You have a patient that was diagnosed with tuberculosis, and they're most likely taking isoniazid. Isoniazid has a structural similarity to the vitamin B6 known as pyridoxine. And so it basically acts as a competitive inhibitor with pyridoxine, and this means that the enzymes that use this cofactor will not be able to function properly. These enzymes are responsible for creating neurotransmitters. And so you're going to start to see some sort of nervous system disorders come up in people that are taking isoniazid and are not taking vitamin B6 along with it. The kind of symptoms that you're going to see is going to be paresthesias in the distal extremities, such as the hands and feet, and you may also see ataxia from decreased peripheral proprioception and also decreased pain sensation. The typical gram stain for Neisseria gonorrhea is going to be numerous neutrophils with intracellular organisms, and one of the main virulence factors of gonorrhea are the pili, basically the little appendages that the bacteria is using on its surface to move around and attach to things. This is what allows it to attach to epithelial cells in the first place. And one of the main things about these pili and why people don't develop long-lasting immunity to Neisseria gonorrhea is because these pili undergo antigenic and phase variation. And so what's the difference to that? Basically, they can stop expressing the pili altogether, and it goes in like an on and off expression, and this is what we mean by phase variation. And then antigenic, basically meaning the actual antigenic profile, right? The actual proteins that make up this pilus could change, and so that it's constantly keeping the immune system on its toes. Compartment syndrome cannot just be caused by trauma or by some direct impediment of blood flow. It can also be caused by acute exertion, and there is this entity known as acute exertional compartment syndrome. And so this is basically a history of a person that has been training very, very intensely for a period of time, and then they come in with all the signs and symptoms of compartment syndrome in a particular extremity. So, typical things such as ischemia, myonecrosis, nerve damage, basically going to express itself as numbness, pain, severe pain that increases, pain with passive stretching of the affected muscles in the compartment. But more importantly, it's going to be weakness, right? And this can kind of look like a DVT, but the difference is that a DVT is not going to cause any neurological symptoms of numbness in the extremity. And the history should also give you an idea of the difference between DVT and acute exertional compartment syndrome. Children who have signs and symptoms of ADHD, you can either start them with pharmacologic treatment or you can use non-pharmacological interventions such as behavioral therapy. The main difference of when you're going to pick one over the other is essentially going to be age. So with kids that are kids that are less than 6 years old are going to get behavioral therapy first, specifically parent-child behavioral therapy. If they are older than 6 years old, equal to or older than 6 years old, they can get initial treatment with pharmacology. If you're going to go ahead and start a kid on methylphenidate or amphetamines for ADHD, you have to do a cardiac history and physical examination first, because classically speaking, there has been an FDA warning of sudden cardiac death with stimulants. And so you have to make sure that there is no cardiac disease, do your regular physical, and if there is some kind of weird thing showing up with the cardiac disease, then you do a ECG screening. But if everything checks off, then you're good to go and you can start the pharmacologic therapy. So if you have the situation that you started giving the medication and the child has continued symptoms or intolerable side effects, you've maxed out the dose, right? You've titrated the dose all the way up. You've maxed it out. Still, it doesn't have 100% improvement. They've had it for about, let's say, 2 months already. At this point, you can switch to an alternate ADHD medication. And the alternates that you have are the norepinephrine reuptake inhibitor known as atomoxetine or an alpha 2 adrenergic agonist. Get used to seeing the clinical presentation for hyperthyroidism, even when it's in children. Okay, and a lot of times it can be behavioral changes. Okay, so being moody, being irritable, crying, stuff like that. And then you're going to have the other physical conditions that also arise with that. So you're going to have weight loss, tachycardia, hyperreflexia, could be like 3+ deep tendon reflexes, skin being warm and moist. Another thing is lid lag. And so I don't like the word lag. It kind of it does term sounds counterintuitive to me. It kind of sounds like somebody who was smoking weed and their eyelids are literally sagging down. But lid lag is actually going to be the opposite of that. It's when the eyes are very open, and so that you can see the sclera above the iris. You can see the whites of their eyes above the iris, when in most people, in the average person, that's not the case. Long-term complications for untreated hyperthyroidism includes arrhythmias and dilated cardiomyopathy. Another one is osteoporosis, and this is due to thyroid stimulating hormone stimulating calcium and phosphate release from bone. Femoral neck fractures due to osteoporosis don't just occur in frail old women. They can also occur in older men, specifically over the age of 65. And this is actually the highest risk factor for osteoporosis in men, is an age greater than 65. Other things that are associated with osteoporosis would be heavy alcohol intake, which is more than 3 drinks a day, low body weight, cigarette smoking. Other things, non-modifiable risk factors, postmenopausal women, being white or Asian for whatever reason, a malabsorption disorder, conditions such as hypercortisolism, hyperthyroidism, or hyperparathyroidism, inflammatory disorders such as rheumatoid arthritis, chronic liver and kidney disease. Modifiable things, we talked about alcohol, we talked about smoking, a sedentary lifestyle, medications such as glucocorticoids and anticonvulsants, vitamin D deficiency or inadequate calcium intake, so get out in the sun and drink some milk, or estrogen deficiency, which may come from premature menopause or an oophorectomy. In explaining cardiorenal syndrome, this is basically when you have a condition of the heart such as a cardiomyopathy, or more specifically, when you have heart failure, okay? And in heart failure, if you have an exacerbation of this heart failure, the kidneys are going to sense that as if there is a very low volume. And so this is known as reduced effective arterial blood volume. And once the kidneys sense that, they're going to activate the renin-angiotensin aldosterone system, which causes vasoconstriction and volume retention. And so this is basically going to continue exacerbating the whole situation. And then the load on the left ventricle is going to increase, but we know the left ventricle is not capable of handling that increase in load. And so it's just going to be a vicious cycle from that point forward. And then what you're going to see is acute kidney injury. And acute kidney injury can basically be determined from laboratory tests with blood urea nitrogen and serum creatinine. And if you see a 20-to-1 ratio between BUN and creatinine, then this is suggestive of a pre-renal cause to acute kidney injury. So pre-renal being the fact that there's not enough blood getting to the kidneys. And one question that may come up for you is, what is the major driver of AKI in cardiorenal syndrome? And this will be elevated central venous pressure, which reduces the glomerular capillary filtration gradient. And then everything goes downhill from there until you come in to save the day. The use of antipsychotics in the elderly with dementia increases their risk of mortality. And it could be mortality from several different things, such as increased rates of cardiac events or complications from strokes, from aspiration pneumonia, from falls, all types of things. So you need to have informed consent if you decide to start an antipsychotic on an elderly patient with dementia. You need to educate the family about these risks. Now, the benefits, why would you do that in the first place? Because this person with dementia is really starting to act out of hand and they're starting to get dangerous, okay, for themselves or for others. So that's the only situation where you would even consider starting using antipsychotics. And when you do, you have to start with a low dose and you have to plan to use it for a short period of time so that there's going to be continuous reevaluation of the situation so that you can work to eventually get the patient off this medication. This is a situation where short-term benefits outweigh long-term risks.